Thank you, Congresswoman. And with me today is Dr. John Bloom, CEO and co-founder of Podimetrics. So John, what problem is it that you're trying to solve?
Well, diabetes, of course, is a big problem, but what's not as well recognized is about a third of the cost of diabetes is linked to complications of the lower extremity, the foot and the leg, usually driven by wounds on the bottom of the foot that can progress it to amputations. Amputations, if they happen, they reach high rates of immobility, high rates of depression, and unfortunately, very high rates of mortality. A single amputation can cost as much as $100,000. With new advanced technology, right, we can see many of these well before they happen to try to eliminate this problem from occurring.
So John, who is the typical patient for Podimetrics?
The typical patient for Podimetrics is a patient who's had diabetes for a longer period of time, and that diabetes isn't always optimally managed. And as a result, we might see multiple organ systems affected for this patient. They often have significant heart disease. Smoking can be quite prevalent, so they can have significant rates of COPD. Their kidneys can be affected. Diabetes affects the entire body. This is a patient also that it affects patients with racial or ethnic minorities, patients with lower socioeconomic status. It's one who doesn't have the same levels of access as we might take for granted in a lot of other populations. Because of that, this is a very, very high-risk patient. They'll typically get a lot of their care in the ER or the hospital. It's challenging to get preventative care to this patient. You can imagine right now, of all times, because of COVID-19, where preventative care is limited because either the clinics have been, we'll say, limited in their throughput, or also this patient is frightened to leave their home to come and see some of these visits. Now of all times, they're especially vulnerable. The same patient who gets diabetic wounds and is at risk for amputations is the same patient that's at risk for COVID-19. It's the elderly patient with diabetes, obesity, lung disease. This very patient now of all times, we need to make sure we keep them healthy in their home.
So John, specifically, how is Podimetrics solving this problem?
Yeah, a big part of solving this problem is getting the care to them in their home. One of the main ways we do this is we provide them a wireless and cordless mat that goes into their home. The idea is just step on it for 20 seconds a day and go on with the rest of your life. That's all the time we need. It has basically an embedded cell phone inside of it that broadcasts the data to us. And then we're looking for early signs of tissue breakdown. If we see any of that, we then have one of our nursing team connect with the patient and do very simple preventative care to hopefully prevent the entire episode from occurring. These are very simple things. Have them walk less for a short period of time. Of course, and if that doesn't work, we can escalate them at that very moment that they need it to be seen by a clinician. So that if they need it, often if it isn't something you can just address by walking less, it's typically just callus. Clinician knows to quickly debride that region, and that usually ends the episode from occurring. So both of those together, it allows us then to keep a close eye on this patient population and get care to them the moment that there's an issue, as opposed to waiting them to present in the healthcare system otherwise.
So are your customers seeing results from the prevention of foot ulcers?
Yeah, we've seen a lot of data come out actually very recently. We had a study that came out, I believe this week, looking at Kaiser Permanente, a population that they were managing in the DC area. It was a very high risk cohort. Over, I believe, 57% of patients had already had a partial foot amputation before they were enrolled in the patient population. So a very, very, very high risk cohort for continued amputation, et cetera. What we saw in this patient population was a 52% reduction in all-cause hospitalization. Right, it was virtually all the diabetic foot hospitalizations, but we also saw hospitalization reductions in things like stroke, myocardial infarction, COPD exacerbation, and CHF exacerbation. A lot of that has to do with that nursing layer, right? If they have a change in adherence, that prompts one of our nurses to call the patient and then ask a very simple question, how are you doing right now? And we often find out things short of breath. It can be a number of things that you find out because of that we knew to ask them just because of that change of adherence. We also saw a 40% reduction in ER visits, a 26% reduction in outpatient visits. Both of those are all cause. And then most importantly, we saw a complete elimination of all major amputations. We see the same thing from early data coming out in the VA across the VA centers in the nation. No one should have to lose a limb to diabetes. If you can detect these signals early enough, then it's simple a matter of getting the right, easy to do preventative care to try to prevent that episode from occurring.
We hear a lot about values-based or outcome-based care. How does Podimetrics play into that new model?
Yeah, it was funny when we first started, we heard a lot that prevention doesn't pay. This mantra that actually it could be quite scary to a lot of companies coming out. And I think in a typical fee-for-service type environment where your whole goal is to limit resources, limit services, that isn't necessarily a perfect environment for a system like that to get adoption and drive the outcomes that we want. What's been amazing about outcomes-based plans, and Medicare Advantage being a primary example, is now everything is aligned. Now we can roll out to this patient, and now we're trying to get the best possible outcome, which often you don't need, no surprise, you don't need the amputation to get the best possible outcome. Now, if it's just a simple matter of walking less, something inexpensive to do, we have the chance of preventing significant complications from happening in this patient population. And again, it's all a result of aligning incentives across the board.
What alternatives do people have if they're not using the Podimetrics mat and system?
Still today, by far the most common approach is daily foot checks. You try to get them into the clinic as often as you can. Usually it's every 61 days. That's the Medicare's maximum you can bring them in. You try to give them shoes and insoles. And sometimes you can give them mirrors, even help the bottom of their feet. A lot of it is even education to the patient. Fortunately, it's still very challenging. Even with that, that's the current baseline that we use in our clinical trial to compare against. With that, there's still challenges with how regularly they're going to inspect their feet. There's challenges with a number of things. So that's still the best that we have. And the other part is if they see a challenge, you have to hope that they really understand exactly what it is that they see. I remember, unfortunately, all too often, I would be in the ER. We would see a patient come in. I remember one in particular, and her legs are both wrapped fairly significantly with it. She didn't really understand what was going on. It wasn't until her daughter noticed a change in just how her legs, how they smelled, knew that she needed to be seen. And when we saw it, we took down the legs, the leg wraps. We knew that this was a fairly, unfortunately, this is a case that was probably going to require both legs to be amputated. So it's a very challenging part. A lot that just we can continue to work on with education. There's a lot of challenges here that is the current state of best care we have prior to adding on preventative technology.
And you've made it very simple once somebody receives that mat to step on it for 20 seconds. But we know it's really hard just to get the person onboarded and to truly get them engaged. How does Podimetrics do that?
Yeah, typically when we work with the health plan to help stratify their patients into high risk groups. It's not every patient with diabetes that would need to get the system. You're really looking for somebody who's has had a wound recently and that has closed. That's unfortunately, if you get one and you close it, your probability of getting another one in the next 12 months is about 40%, almost a coin flip to get another potentially 40K complication to take care of, plus another moment where they're at risk for losing a limb. So once we identify those patients, usually then we can get the information. We'll work to get the doctor to write the right script. It also helps us have better relationships with those clinicians. And once they have the script, we reach out to the patient to see if they would be interested in enrolling in the program. But what they do, then we can mail them the device directly. We do phone training. They never had to leave the home for us to onboard them, which is, again, is critical given the current pandemic and just their vulnerability to COVID-19 and a bunch of things. So very, very low, minimal impact to the clinical practice, minimal impact even to the plan that we work with. We take care of all that to make sure that the patient is an active user.
Most health plans have care management specifically focused on diabetes. How does Podimetrics interact with the health plan?
So I think that interaction, that handoff is going to be critical for us, and it continues to be. Often we'll find things as not just a diabetic foot issue. Sometimes we'll find out there's worries of heart failure, COPD exacerbation. We then compare right back into that care manager and let them know what we're seeing. They then have all the right relationships. They can work with that patient. We're basically an extension of their capability, but into the home with real-time parameters, allowing them to be more efficient with their time and a lot more impactful to outcomes.
We're here with our colleagues that all work in Medicare Advantage. What's the one thing they can learn from your experience?
Yeah, I think probably the most critical lesson that we learned was that, especially for this patient population, one that's had challenges with engagement for a long time, is that you can't just take a piece of technology or service and then push it out to that population. You really have to take time in the home, really try to understand how this patient interacts with their home, their workflow, and design it specifically for their needs. For example, a study came out in JAMA maybe 6 weeks ago that said that 41% of Medicare beneficiaries lacked access to either an internet-connected phone or computer. So if we give them a new phone app to use, that's not going to have this. It's not going to have the same impact. It needs to be regardless of education background, regardless of availability of technology. And it wasn't until we really understood exactly the needs of this patient population that we're able to put together a system that was generic across all of them. It doesn't matter where you are, our system should be able to acquire a signal, and we should be able to give you good preventative virtual care.
It seems like virtual care is having a moment right now. Where do you see it going post-COVID?
Yeah, I don't think virtual care is going to go away in the near future. I think we're going to need to do more and more of it. So with the increasing population, the numbers of Medicare patients that we're going to need to care for, very traditional one-to-one models of care, one doc, one patient at the same time, that's not as scalable as we're going to need it to be. Passive systems that allow us to do one-to-many, whole populations, I think are going to be the only way to do very efficient care and affordable care, right? To manage all those patients at the same time. So I think even though we're seeing its sudden emergence across a number of environments, that's exactly where care is probably going to stay. It's just a more affordable model and a lot more efficient model for delivering good care.
Well, thanks, John. That's all the time we have now, but I understand that one of your colleagues will be sharing more at lunch. Would you care to share that with our audience?
Yeah, you can actually join one of my colleagues, Simon Salgado, for a roundtable lunch discussion in about an hour. He's going to be talking about reaching vulnerable populations with virtual care models.